All right, so this question today, we were asked to consider at which ejection fraction do we consider ICD placement. So the correct answer is going to be 35%, and we'll kind of go through why. So when I think about heart failure, we can break it down into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. We're just going to talk about the reduced ejection fraction today. We'll talk about HFpEF at another time. When I think about HFrEF, reduced ejection fraction, I can kind of break it down further into a cardiovascular cause, a toxic cause, an infectious cause, or other, right? So cardiovascular causes are going to be things like ischemia, tachyarrhythmias like AFib, atrial regurgitation, and mitral regurg are going to be some of my bigger causes. Toxic causes can be like alcohol, amphetamines, cocaine. We also have certain chemotherapeutic drugs like anthracyclines and trastuzumab, the HER2 receptor blockers, and also thyrotoxicosis. Infection-wise, think about your myocarditis, your HIV, Chagas, and sepsis. And then some of my others, there's familial dilated cardiomyopathy, there's peripartum, there's beriberi due to a B1 deficiency, Takotsubo or stress cardiomyopathy, cirrhosis, muscular dystrophy, giant cell myocarditis, and then our idiopathic, right? So that's kind of how I break that down. And then further for like step one land, like what even is ejection fraction? Ejection fraction is a formula, right? We take stroke volume divided by end diastolic volume. We multiply that by 100. Typically, we consider anything less than 40% is our HFrEF, reduced ejection fraction. So when I am thinking about why do I want to put a patient on an ICD if they have a reduced ejection fraction, it's all based on if my heart is not pumping fully, right? We're having decreased forward flow and blood is just stasing around in my left ventricle and my left atrium, right? That's just asking for ventricular arrhythmias to occur, right? It's just asking for electrical instability and a ventricular ectopic foci to occur, leading to potentially monomorphic ventricular tachycardia and even leading to ventricular fibrillation, right? Which can lead to sudden cardiac death. So if we put the patient on an ICD, it can hopefully shock the patient if they go into VFib. So there have been many clinical trials, and I'll post some of them below, that have demonstrated a mortality benefit if the patient has a left ventricular ejection fraction less than 35%. So the way we think about it is based on the new clinical guidelines by the American Heart Association and the American College of Cardiology. We want to think about a patient who has a reduced ejection fraction less than 35%, who's been on optimized GDMT, guideline-directed medical therapy for heart failure for at least 3 months, who has a life expectancy longer than a year, and does not have a reversible cause, right? So when I think about my GDMT, my guideline-directed medical therapy for a HFrEF, there's 4 major classes. There's ARNIs, so sacubitril plus valsartan, and then plus ACE-I or ARB, right? So ARNIs are going to be go-to for that pillar, but we could use ACE-I or ARB. There's my beta blockers, so the 3 big ones that are have proven effective are metoprolol succinate, carvedilol, and bisoprolol. There's my MRAs, my mineralocorticoid receptor antagonists, so spironolactone and eplerenone. And then there's my SGL2 inhibitors, so things like dapagliflozin and empagliflozin. Okay, so optimize, the newer clinical guidelines are calling it like quadruple upfront therapy. So most patients will likely start on all 4 drugs at the lowest acceptable dose and slowly titrate them up. Obviously, there are exceptions to this rule, but by optimize, it doesn't mean that the patient has to be on literally the max dose of all 4 drug classes, but we have had to try to titrate them. The patient is still having symptoms. The drugs still aren't totally working, and their left ejection fraction is less than 35%. If all that is, we're checking the boxes on all that happening, and it's been longer than 3 months, that right there is the indication to put in an ICD. So I will show you guys, or I'll link some of the clinical trials and the 2025 guidelines down below. Let me know if this helped you out. This is a high yield topic for step 2, step 3. And we covered, some of the major causes of systolic ejection fraction reduction in heart failure, right? And so remember, again, that's due to eccentric hypertrophy We could hear an S3 if we listen to the heart, right, when we're thinking about volume overload, compared to HFpEF, where we're thinking about more concentric hypertrophy. We might hear an S4, and that's due to more ventricular noncompliance.